Welcome back, everybody. I'm excited to go through this presentation with you because we're going to step back a little bit. Now, this was yesterday. This is a Monday, and this was Sunday. And I was getting ready for a flight, and I apologize for this photo being a little blurry, but I was actually trying to move the plane and trying to get a picture at the same time, which isn't the safest thing to do, but I just wanted to capture how the clouds looked as I was departing. So at the very top, the top half of the screen shows clouds. The bottom half that's my wingtip, and we're taxiing down taxiway. Now, I was planning this for those of you that are pilots to take this as a VFR flight. And those of you that aren't pilots, what that means is I was moving my plane from my home airport to where I had to have my annual inspection done. That's just an inspection that has to be done every 12 months on your plane. And here it is on a summer morning. I'm thinking, boy, what are all these clouds doing up there? I thought I was going to have clear skies. At this point, I thought I'd be seeing blue skies, although this was a little bit before sunrise. I always like going up before sunrise because it's calm and quiet. And the day before this, on the Saturday, I'd been teaching an endodontic course. And so I was thinking about this at the time, that a lot of times we have to make decisions. What are we going to do? Are we going to take off, or are we going to do the root canal? So what I want to do is just kind of go through kind of my thinking process as we look at this. So if I have a tooth and I've determined that it may need a root canal, before we do the root canal, we have to figure out, is that the best thing for the situation? Just like taking off. Is it going to be safe if we take off? So if I have a badly broken down tooth, let's say, and a root canal could be an option to perhaps keep that root and that tooth in place. Another option might be just to take that tooth out. Well, if I take the tooth out, I have to explain to the patients that if we take the tooth out, maybe we do nothing, which means you're going to have a space there, and the teeth can shift around, and it could be unsightly. It could be unesthetic if it's in an anterior or front area of the mouth. Maybe if we take that root out, we can place an implant. Maybe if we take that root out, we can do a fixed bridge, which means we'll have to work on the tooth in front and back of that space. So I'm going to have to work on teeth that may not even need the work. Or we have a removable option, which is like a plate to replace a tooth or teeth, and it's going to go in and out. So it's kind of like your grandparents' teeth that used to sit on the bathroom counter. The age and the health of the patient. Is the patient 100 plus years old and in poor health? Or I do have patients that are 100 years plus old and they still drive to the dental appointments. What's the need for that tooth? If it's a second molar, maybe they don't need that tooth, especially if they're older and maybe more frail because of medical issues. What's the projected longevity of the tooth? Can I restore it? Is there enough tooth to restore? And if I do restore it, can the patient maintain that tooth? Sometimes my older patients, their dexterity is no longer there and their sight's no longer there, so they come in and they've been brushing and flossing and there's still a lot of plaque around the teeth. Maybe an implant would be better because an implant wouldn't get cavities. If they're a high caries risk patient, I have patients that come in, and every time they come in, they don't just have a small cavity here or there, but they've got multiple cavities that are really deep. So maybe that would not make doing the root canal an advantageous procedure. If periodontally, the gum and the bone isn't strong enough, and I retain that root, is the root going to eventually just come out because of periodontal disease? Something to consider. Occlusion. What are the forces that are going to be placed on this tooth? If there's not going to be much tooth to have a ferrule, then maybe that crown's not going to last, or whatever the final restoration is. Is there enough bone for an implant? So if I've got a tooth, maybe a root, and I think, well, once I take that root out, the bone's going to be very weak, maybe very thin, maybe the sinuses are involved, I don't want to place an implant. So maybe something that's removable will be something we consider. Cost is always a consideration. In my office, if we do a root canal and a crown, it's usually less expensive than an implant and a crown. Cost and time. If I do a root canal and a crown, I can get that done the same day or maybe in a couple of weeks. If I place an implant and a crown, that could take a few months. So ultimately, we run through this with the patient, and then we figure out what the patient's desires are. Endodontics can be successful, but a tooth may fail to heal, even if we use the right approach to our endodontics. And we're doing everything that we've talked about in previous episodes. All right, so let's say we get the patient in. They're complaining about pain. Well, what do we have to do first? We have to figure out which tooth it is. I had a patient that came in the other day, and he was pointing to the second bi area on the upper right side. He goes, "It hurts right here." We took a radiograph and didn't really see anything there, but tooth number 2 had some deep decay. I said, "Well, maybe it's this back tooth," and he goes, "No, it's this area right there." So what we had to do is we had to localize the pain, and I'll explain to you how we did that. Then I asked the patient, "Well, when did the symptoms appear? Did it just happen today? Did it happen a week ago? Did it happen a month ago? And when it does happen, how intense is that pain?" Sometimes we have patients and they drink some cold water or hot coffee, or maybe they breathe in the winter when it's really cold air, and they feel that coldness there, and it's just very transient, comes quickly and goes away quickly. That tooth probably doesn't need a root canal. It's just a normal response. And I explained it to the patient. Sometimes with certain teeth, when hot and cold hits them, they feel it. That's because the nerve inside the tooth is healthy, and then it goes away really quickly, right? That's a normal recovery for a tooth. And then I asked them about the provocation and the attenuation. Okay, what produces the pain that you feel, and what makes it feel less painful? So if the patient says, it feels sensitive when I drink something cold, but when I drink something hot or eat something hot, it makes it actually feel better. Then I'm starting to think, okay, what does that indicate about the nerve? Is the nerve healthy? Is it maybe a reversible pulpitis state, or is it irreversible? Or maybe it could be just totally necrotic right now. The duration of the pain, when you do feel the discomfort, how long does it last? Especially if there's something that causes the discomfort, like putting something hot or cold in your mouth, once you swallow that, does that discomfort go away right away, or does it linger and stay in your mouth for 5, 10, 20 minutes? Then we get in and we do the examination. Well, before we go inside the mouth, we're looking for anything that's extraoral. Is there appearance of swelling being anywhere? Is there a sinus tract where it's actually draining already? If nothing like that exists, then we go intraoral. Look at the soft tissues. I'll start to use percussion, tapping on the teeth to, again, localize it. I'll go to see if there's any mobility, because that would indicate the periodontal situation, and or if there's a lot of swelling, like pus around that root. I'll do a periodontal examination to see if there's an isolated deep pocket, which oftentimes will be indicative of a vertical fracture. I'll get in there and do pulp testing. Usually I just do the cold, and I'll explain how I do that, but there are other tests you could do: hot, electric, Doppler, pulse oximetry, lots of different tests, but I usually just do the cold. Then the bite test. I'll have the patient bite on different parts of the teeth, on different teeth, to see if it hurts when they put pressure on that tooth. And if they bite down and it hurts when they release, then many times that's indicative of a possible fracture in the tooth. So if there's a possible fracture, then I'm going to look at transillumination to see the crack, staining, and or today I might use biofluorescence. And we talked about that in a previous episode, a YouTube episode. I'll look visually. What do the teeth look like? What do the gums look like? Is there any swelling of the lip? In this case, there wasn't. Then we take a radiograph in that area. So now that I've kind of gotten an idea of where that discomfort's coming from, maybe it's tooth number 8, 9, or the 1121. Now I'll have my assistant take a radiograph in that area so we could look underneath the tissue. Today we also have CBCT, which is also very valuable. So we'll talk about that. Once I get that PA, then I'm going to start looking at the restorability. Like on this tooth here, you can see that we have really deep decay right at the level of the bone right now. By the time I remove that decay and place a margin, we're going to be subosseous. So do I want to restore that tooth? It's a judgment call. Depends on how strong the other parts of the tooth is. Can I do some crown lengthening here so we don't violate the biologic width? We have a lot of different things we have to take into consideration. On the top, you see some periapical radiographs that show a fractured root. So if I see that, then it kind of answers that question. We're not doing a root canal. We're probably going to do an extraction there. On the bottom, you see a CBCT. That CBCT, because I also often have doctors will ask me, well, how do I know how many canals there are? And I'll ask them, well, do you have the ability to take a CBCT image? Because like you see in this image here on the bottom, that indicates that molar has 5 different canals. So that can be very helpful if you have the technology. Now I'm going to locate the tooth and I'm going to try to replicate the symptoms. I want to see if the pulp is vital, or maybe it has a reversible pulpitis. So I'm going to tap and use my endo ice. If I want to look for fractures, then I'll use the probe, as I mentioned before, have the patient bite on the tooth, a tooth sleuth, transillumination, or a dye, or the dye. Sometimes in place of the dye, I'll use biofluorescent technology. And something else I want you to consider, that we had a run of patients for a week where I had a lot of patients coming in saying that they had toothaches. And so I was thinking root canal. And when they would come in, I'd be looking at the teeth and they'd say, well, it doesn't really hurt there, but it hurts back here, like behind the jaw. And so I'd palpate the muscles back there and I'd go, yeah, it's really sore right there. But on the radiograph, I didn't see any infections back there that would be draining or causing any discomfort. And I told them it's probably just TMD symptoms, referred pain. And so what I ended up doing is I told them, we're not going to do your root canal. What we're going to do is I want you to follow these steps to let the TMD heal up, and then we'll evaluate it again in a week and see if we have to do the root canal. And I will tell you, I had 1 week where I had 3 of these patients, and I saw them all back a week after that, and they were no longer had any discomfort. So we didn't do the root canal. We just chalked it up to referred TMD pain. So going back to tapping, what I'll do is I'll take like if I have a metal mirror handle, or here I'm using the back end of a cotton plier, forceps, I'll just tap on the teeth. And I'll tell the patient, I'm going to tap on the teeth to see if there's a tooth that seems to be a little bit more sensitive. So I don't do it, to make them uncomfortable or where they jump out of the chair, but I do it where as I tap, the patient can say, yeah, that tooth right there, that's a little tender. So now I start to focus on how the pulp is. Do I have sensitivity to cold that's transient, or is it lingering, or is it delayed, or maybe no response? So what I do is I take a cotton pellet and I spray it really well, hold it on a cotton plier, and then I place it on the tooth. And I'll place it on the buccal facial, I may place it on the lingual, and I'll place it on the occlusal surface. And I ask the patient, when you feel the cold, raise your hand. I'm going to take the cold pellet off of the tooth. Then when you don't feel that cold anymore, put your hand down. And what I'm looking for is when I put the cold on the tooth, if it has a healthy nerve in it, should feel that cold. So the patient should raise their hand fairly quickly. I remove that cotton pellet and their hand should go down, because now that sensation of cold will go away. If it's a disease pulp, not a healthy pulp or necrotic pulp, you'll put the cold on that tooth, they never raise a hand. You put it on the occlusal surface, they don't raise their hand. So what I'll do is I'll spray it again and I'll put it on an adjacent tooth. And now put it on, like in this case, I'm on tooth 27 or the 4-3 here. We put the cotton pellet there, the patient feels it or doesn't feel it. Then I put it on the lateral in front of that tooth, and as soon as that cotton pellet hits that tooth, they raise their hand. So I know they know what it should feel like. I take that cotton pellet away and their hand goes down. So I go back to that tooth number 27 or the 4-3, and again, no response. So now I'm thinking probably necrotic pulp. So reversible pulpitis is where the nerves are irritated. It'll be sensitive, but it'll still recover fairly quick. There could be some transient inflammation. Maybe we just did a filling. Maybe they were grinding on that tooth. But it's reversible. I mean, over time, it can still heal. Irreversible pulpitis may be symptomatic or asymptomatic, depending on where in that irreversibility we are. If that tooth is just starting to kind of go kaput, it may still feel that cold, and then we remove the cold, they feel that cold for another 5-10 minutes, right? It's not transient, it doesn't go away really quickly. If the irreversible pulpitis now has resulted in pulpal necrosis and the nerve has no feeling, we put the cold on there and they may not feel anything at all. So now it's going to be asymptomatic when we put the cold on there. So with the necrosis, the pulp is now going to be unresponsive to the cold test. And if it's a multi-root tooth, sometimes you get some mixed signals. You could put it on the buccal of, let's say, a bicuspid or a molar, and the nerve on that side may feel that cold, but you put on the lingual and they don't feel anything, and now you're befuddled. Just again, you have to interpret what the results are telling you. If they feel the cold and it's lingering, it probably isn't very healthy. If you put it on different areas of that tooth and there's no response, there probably is an area where that nerve is kind of no longer functioning, which means that eventually that patient's going to have a toothache. One of the things that I try to do is I always try to pick up my paraprobe, and I'll probe around the tooth. In this case, on the mesial buccal, there's a 3, in the mid buccal, there's a 3, and on the distal buccal, there's an isolated 7mm pocket. And that typically will indicate that there's a vertical fracture back there, and in that case, a root canal is probably not going to help that tooth because we've got a deep vertical fracture. This was the bat tooth, the one to the far right, was that the situation where if you look like there's some calculus there, so the patient came in complaining of discomfort, so we cleaned that area up really well. There wasn't a large restoration there. You see a little MO on that tooth. And when probing around that tooth, there was a deep pocket on the distal of that molar. So we gave it some time. We wanted to see if the tissue would heal, and it never really healed it very well. We referred this one to the endodontist for just a second opinion, and the endodontist said there was a vertical fracture and this tooth should be removed. So, if I'm not sure, if there's nothing really obvious, then I will refer the patient out for a second opinion and just kind of see what's going on. So as you probed around this tooth, it was 3, 3, and then a 7+ on the distal of that second molar. Tooth sleuth is something that I will use, and it's just a plastic instrument with kind of a little point on it. And I will tell the patient, I'm going to have you bite down this plastic instrument. The pointed area is going to be on the tooth area that's been sensitive. I'm going to have you bite down. Now, if it hurts, you don't have to squeeze hard. Remember, they're controlling the pressure that's being placed on that tooth. And I'll place it on the tooth and the occlusal surface. I'll place it on the different cusp tips and just have the patient bite down and see if there's an area, a specific tooth area that's tender, or if there's a specific area of the tooth that is tender. And then we have our pink wave curing light. In our pink wave curing light, we have the transillumination setting. I can put my diagnostic tip on here and just illuminate the tooth. Sometimes when we illuminate the tooth, we'll see the little fractures. And so if I see a fracture, I may now go back with my tooth sleuth and say, okay, let me see if the patient bites down that area, if they experience pain. Because there could be a true fracture. This could be more than just craze lines in the enamel. If I still have a question, I could use something like methylene blue dye. I can place that on the tooth where that crack has been visualized with the transillumination and see if the dye traps in that crack so I can visualize it better. As I mentioned before, articles now are saying that we can get referred pain, meaning there could be a TMD issue that's being referred to other parts of the mouth, and it makes it feel as if the patient has a toothache. So here's a video just showing how a patient can have pain in the joint area, making it feel like the upper maxillary teeth are tender or sore. Or we could have an anterior temporalis muscle that is a trigger point, making the anterior teeth feel as if they're sore. So we can have this type of referred pain, and I always like to look at this and consider this before we do the root canal. In this area, the angle of the mandible, pushing down there could be very tender, and the patient comes in reporting pain in the lower molar or bicuspid area. Now, typically, their description of the pain is going to be a very diffuse area. It hurts in this area. Okay, it hurts in this area, but which tooth? I can't tell which tooth. It's just in this area. And so I might go through my tapping, might go through my tooth sleuth, may go through the ice testing, endo ice, and everything appears to be normal, but they'll say, but it hurts in this area. So if they say it's a very diffuse description of the pain, then yeah, I'm thinking TMD. Let's follow some TMD protocols and see how that pain does. So this is a case where a patient comes in and they have tooth number 9, and tooth number 9 has a periapical radiolucency up there. No spontaneous pain, but the patient says when they press up above the root of that tooth, it's a little tender up there. No pain on biting, no hot or cold discomfort. So what does that possibly mean? Is that the nerve is gone, right? I put hot or cold on that tooth and the patient doesn't respond because there's no nerve in that tooth to respond anymore. And what you saw in this text is I asked the patient, I said, everything looks really good. Was there any trauma that you suffered on this front area? And he said about 5 years ago, he had been in an auto accident and suffered some trauma. Front teeth hit the steering wheel or the dash and was very knocked hard and bruised, but never anything more than that. So I always tell the patients, that traumatic incident probably caused the nerve to die over time. It didn't happen right away. It happened over time, and that's why it's getting so sensitive right now. We should consider doing a root canal. So the chief complaint, does a patient report pain? In this case, they did not. It was just when they were pressing on the apical area of that tooth area. Is there radiographic evidence of a periapical radiolucency? In this case, there is. So now we're thinking a necrotic pulp. And if there's a necrotic pulp, a root canal can be indicated. So going back to that flight, I did take off yesterday morning, and I did manage to safely get above the clouds. And once you could see it was kind of broken up in areas, so I was able to get through the clouds without breaking any rules. But it's one of my favorite times to be up and above the clouds, because it looks like just cotton out there in the sky, and you're just kind of above it. And I got my plane to my mechanic. So once you diagnose the need for the root canal, and you determine that it's going to be the procedure that's best for the patient because there's enough tooth to restore, the patient can maintain it, and maybe cost-wise it's the most efficacious treatment to render, then you have to think, okay, it's now your call. How do you feel? Do you feel fearful thinking about the possibility of doing a root canal on that tooth? Do you feel apprehension, or do you feel confidence? Hopefully, after you've been watching these programs, you feel confident. It's one of those things where if I can do it, I know you can do it. So what's next in your office? Are you going to refer? Are you going to go ahead and do the root canal and get it taken care of for your patient, which your patient will really appreciate? So this is just kind of a view looking out yesterday morning. Again, it was before the sun rise, and so we had a really nice red-orange sky. And once you're above the clouds, it was just serene and peaceful, and just made for a very enjoyable morning. So if you like this information, and I hope you do, hit like, subscribe so you don't miss out. We are creating a group, a community of like-minded clinicians who are always trying to learn and do the very best for their patients. Today we were focused on endodontic procedures, diagnosis, and that decision tree of, is the tooth best served by doing a root canal, or should we consider something else? And then we got to the end where, okay, if we need to do a root canal, are we going to do it? Who's going to make the call? Hopefully it's you, and you're going to successfully do that root canal and live to fly another day. Anyway, good to be with you. Thanks very much for your time. And again, hit like and subscribe, or type in some comments. I'd love to hear what your thoughts are. We can learn through the exchange of ideas. Thank you very much. Bye-bye.